Good afternoon, everybody. It's me again. I'm back. Nawala kanina. I had some technical issues. Well, what happened, I updated my MacBook and then after nag-update, nag-restart. Tapos nawala yung aking internet connection. I need to reconnect myself sa internet. But anyway, I'm back. It's 1:22 p.m. So I was out for almost 30 minutes. Okay. So it's 1:33 p.m. Central Time. And gaya ng sinabi ko, I bet it's morning in the Philippines. Good morning, Philippines! Good morning to all my relatives, friends, students back home. So I am glad that even we are miles apart, we had a chance to ways to reconnect. And I'm just glad, as promised last night before I ended my ABG concept, it's a brief overview about arterial blood gases. I made a promise because a student dropped a request if I can talk about electrocardiography today. And I said, yeah. So once na I'm awake, I'll talk about electrocardiography, even if I have not taken a shower. Would you believe that? So hindi naman siguro, I can't deny it, hindi pa ako nakapag-shower. But who cares? You cannot smell me, guys. Di ba? Ang importante is that what's important is my concept today. So just a disclaimer, your electrocardiography is quite lengthy concept. So I decided to make two parts of this stream. The first part this afternoon, and the second part will be tonight. Okay, so expect that I will have another streaming tonight, let's say around 8 p.m. my time, Central Time. So for the first part, we'll talk about an introduction about cardiovascular system. I have a need to discuss this before we will touch electrocardiography, because you must know the basic foundation of conduction system in the heart. Now, why? So that you won't have a hard time when we talk electrocardiography. I don't want you to end up having petit mal seizure like blank stares. What is he talking about? So I think this will be helpful for those who are planning to take the qualifying examination here in the U.S. Not only in the U.S. but also wherever you're planning to take your nursing qualifying exam. Okay, so for those who are new here, my name is John Gilrica Fort. I'm a nurse. And then that's my first course. After a few years finishing Bachelor of Science in Nursing, I took up another course, Bachelor of Science in Respiratory Therapy. And I've been doing coaching for qualifying examination even when I was still in the Philippines. So this is not new to me. I've been doing this for 21 years. So I'm just glad that with the technology we have, even if we are miles apart, okay, as long as you have an internet, your means to learn is actually endless. Okay, so if you have any questions, comments, or anything, suggestions, anything you want me to discuss after this concept, let me know. And I will try. Okay, if I don't know the concept, I will let you know, guys. Okay? I think everybody's ready. I'm ready. Nakapag breakfast ka na ba? Hindi nga breakfast, so it's 1:25. So it's no longer breakfast time. Well, later after this, I might go to Calzada. If you're staying within the city, Minneapolis, you go to Calzada. They serve good food there. Anyway, let's try to turn off the background music and let's talk about cardiovascular system. There. Okay, so let's talk about electrocardiography. Let's begin with your cardiovascular system. Okay, a little introduction. I'm not paid to do this, but if you know Promil users, it's a brand of milk in the Philippines. Promil users, they said the Promil users are considered. They say that they're gifted children, right? Sabi nga, one of the advertisement in the Philippines is Shaira, if you know her. Shaira, Promil user since birth. Sabi nga ni Shaira, cardiovascular system is a system that circulates blood around the body. That's correct. So the main function for cardiovascular system is to pump the blood out. Okay. So hold on, let me share my screen. There. Share it. And whiteboard. Nope. There, that's my whiteboard. Oh, ito po yung topic natin kagabi. There. So let's talk about cardiovascular system. Let me see if you can. Nope. I think this is better. I just want to make it sure that. Okay, hold on. Give me a few minutes. I want to make it sure that nasa tama akong screen. At baka may makita ka hindi ka nais-nais. Anyway, so cardiovascular system is a system that circulates blood around the body. That's simple. Okay? So, bakit color? Yeah, let's use color blue. Oh no, mas maganda yung black. Okay, here. Cardiovascular system. Okay, so when you say system, it's a collection of different structures. Why am I looking at the light? Why am I looking at you? So I need to steer. That's the camera. So when you say system, system is a collection of different structures or different organs. And when they work together, they serve one purpose. That's your system, right? Connections of different structures, different organs functioning as one. So in your cardiovascular system, there are different structures here. Cardio, that's your heart. Vascular, that's your blood vessel. And inside your blood vessel is your blood. Okay, so that's your cardiovascular system. Okay, a cardiovascular system is a closed circuit. Okay, so once the blood pumps the blood, okay, once the heart, once the heart pumps the blood out, the blood enters a closed circuit. Okay, and you call it closed circuit as your blood vessel. And I've been drawing this for several times, even sa fluid composition, na drawing ko rin ito. So this is our heart. We know this heart has two sides, the right side of the heart and the left side of the heart, correct? The heart is a hollow muscular structure that the main function is to pump blood. The right side of the heart receives and pumps deoxygenated blood or a blood that has poor oxygen concentration. The left side of the heart receives and pumps oxygenated blood. So technically it's blood rich in oxygen. So when the heart pumps blood out, I said this, it passes a closed circuit, and that is your blood vessel. A blood vessel connected on the left side of the heart, we call that as your artery. A small artery is what we call arteriole. Okay. And as the blood passes through there, okay, remember artery, the direction of blood flow is away from the heart. Okay, so that blood enters an artery, gets inside the arteriole, and it passes another blood vessel. We call that as your capillary. Okay, capillary. We know for the fact that capillary, as an anatomical structure, it has a very thin membrane, correct? Because of its characteristic, a very thin membrane, it's permeable, it's easy for diffusion to take place. You know, diffusion, fusion? It's an anime, fusion. Okay, Dragon Ball ba yun? I believe so. So there's movement of molecules from a higher concentration to a lower concentration. So it is in the capillary area where exchange of gases happen. Okay, so the oxygen from the blood gets out and oxygen enters the cell, and the cell now will exchange that with your carbon dioxide. Okay, so oxygen gets out from the blood, oxygen enters the cell, and in response, the carbon dioxide from the cell gets out, it enters the bloodstream. So there's what we call gas exchange. The gas exchange happening there in the specific environment, we call that type of gas exchange as your internal respiration. So take note, there's such thing as internal respiration and external respiration. So by definition, internal respiration refers to gas exchange between the blood and the tissue, or blood and cell. So oxygen gets out from the blood, enters the cell, and carbon dioxide enters the blood. Okay, that is why when the blood enters on this side, okay, look at the monitor on this side, that is the area where another blood vessel is situated. Okay, the blood vessel on the right side is what we call the vein. Okay, a small vein is what we call venule. That is why when you say vein, it carries blood poor in oxygen but high in carbon dioxide. And the direction of blood flow in this area is it directs blood back to the heart. Okay, back to the heart. Kaya nga, V vein, V vac to the heart. Okay, artery A away from the heart. That explains, nurses, that the heart on the right side receives and pumps a blood deoxygenated or blood poor in oxygen. Whereas the blood on the left side, it pumps a blood rich in oxygen. And we will know later on why it happens. Okay, so the main function of the heart again is to pump the blood out. But hold on, now, since we mentioned artery and vein, there are vascular diseases that will greatly affect the artery, and there are also vascular problems or issues that will greatly affect the vein, correct? Okay, so anong dapat tandaan sa examination? Positioning is important here. If a patient, okay, hold on, may comment. What is this? Okay, if a patient has an arterial occlusion or arterial problem, or arterial issue, if you have an arterial problem, how would you position your patient? Okay, an arterial problem, the position here is to dangle. Okay, dangle the affected part. Why will you dangle the affected part? To promote circulation. Okay, now if a patient has a venous problem, just like your varicositis, just like your deep vein thrombosis, those are conditions that will greatly affect the vein. Okay, so venous occlusion, venous problem. So if you have a vein problem, okay, if there is occlusion, of course, back, okay, the flow of blood back to the heart is affected. So how will you position the patient? Here is to elevate. Okay, elevate. So take note. If it is a arterial occlusion, arterial problem, dangle. If it is vein problem, you elevate. What is the purpose of elevating the affected extremity or affected part? The purpose of doing that is to promote venous return. That is why I formulated a mnemonic for this, and I call that mnemonic as Dave. Okay, that's the mnemonic I made, Dave. So artery, vein. If it is arterial problem, you dangle. If it is venous problem, you elevate. So you know the reason why. Okay, so arterial occlusion will most likely cause cold skin to touch or cold skin. Okay, venous occlusion will most likely cause warm skin to touch. Okay, so they differ whether the occlusion happens in the arterial area or occlusion happens in the vein area. Okay, so anyway, so the main focus of this concept, this part one, case streaming, is the heart. Okay, so we know for the fact that the heart is as big as your closed fist. 2/3 size of the heart is situated on the left side, and the other 1/3, the remaining 1/3, is on the right side. So big part of the heart is actually situated on the left. Kaya nga may saying dati that since your heart is more on the left side, do not believe your heart because your heart is not always right. O, di ba, nakakaloka? Your heart is not always right. Okay? Your heart is on the left side, so it's not always right. Okay, anyway. So, hindi siya nakakatawa actually, pero may sense siya, di ba? So, the main function there of the heart is to pump the blood out and is situated in your mediastinum. The heart is protected by the rib cage. Okay, so your rib cage here. Taray ng demonstration. Ganito talaga. Okay, rib cage is here. Mediastinum is on this side here. And then actually your rib cage will also protect your lungs, the pulmonary area, not only the heart. Okay? So when I say heart, dito na tayo. Heart. Okay. The main function of the heart is actually to pump the blood out. Pumping. Okay, pumping mechanism is a pumping structure, is a pumping muscle. Okay, to pump the blood. Okay, to pump the blood, to circulate the blood so that cells can survive. Vital functions can work well. So any disturbances in the heart, may it be contractility, may be pumping mechanism, may it be the heart rate, it affects perfusion. Okay, simple as that. So if you have tachycardia, a sustained tachycardia is not good. If you have bradycardic, it's not also good. We're talking about the abnormality, okay? Kasi may mga pasyente tayo na normal sa kanila na bradycardic. Ibig sabihin yung si bradycardia, a heart rate of less than 60. Paano siya naging normal? Kaninong normal yung bradycardia? Bradycardia is common and normal or expected. Okay, I think that's the right term. Expected to athletic people. And bradycardia is also expected to elderlies. So don't be surprised if your elderly is bradycardic. If an athletic people, okay, is bradycardic. Magiging concern siya if bradycardic ka and you're symptomatic. Means to say you have lightheadedness, you manifest something because of a slow heart rate. So anyway, so that's the main function of the heart. And we know for the fact that the heart has three major layers. This is elementary. What are the three major layers of the heart? Okay, let's start from the outer part. So we have here your what? Of course, you have your pericardium. Okay, and then you have your myocardium, and then you also have your endocardium. So this is the outer layer. This is the middle layer, and this is the innermost layer. An inflammation on the pericardial layer is what you call pericarditis. Myocardial layer inflammation is the myocarditis, and in the endocardial layer is your endocarditis. If the three layers are actually inflamed, okay, inflamed, we call that condition as your pancarditis. Okay, huwag kalimutan that the endocardium is the innermost layer. If you have any disturbance, not actually any disturbances, if you have an endocarditis or infection in the endocardial layer of the heart, the problem here is that since it's the inner part, it will most likely affect the valves. Okay. Anyway, let's proceed. Now, in the heart, there are two common valves. Okay, two valves in the heart, two valves. Okay, tell me something about valve. A valve is made up of a connective structure, a connective tissue. And what are the two valves in the heart? Okay, two valves in the heart. We have here your AV valve. Okay, I will show the picture in a bit. The AV valve, and you have your semilunar valve. Nakakaloka, nagsulat talaga sa Rica Fort. Okay, so when you say AV valve, it is a valve that can be found between the atrium and ventricle. Okay, now remember, if this is your heart, our heart is divided into four chambers, right? We have the right atrium, the left atrium, the right ventricle, and the left ventricle. These two sides are actually separated by a membrane called septum. Okay, a septum here is the atrial septum. A septum in this area is ventricular septum. We call that as your atrioventricular septum. Okay, so between the atrium and ventricle on the right side, there is a valve. Okay, you call that valve there as your AV valve. There is another AV valve on the left side. It's between the atrium and the ventricle. So technically, when you say AV valve, there are two valves under AV, okay, and the AV valve on the right side and the AV valve on the left side of the heart. An AV valve on the right side of the heart is what we call the AV valve on the right side of the heart. What do you call the type of AV valve there? You call that a short tricuspid valve. Now we call it tricuspid because it has three cusps or three flaps. On the left side, there's another valve there, an AV valve. We call that a mitral valve. Okay. Mitral, or you also call this a bicuspid because it has two cusps or two flaps. Bicuspid. Bakit may S yan? Bicuspid valve. Okay, so tricuspid and mitral valves are examples of what we call AV valves because these valves can be found between the atrium and the ventricle. When you say semilunar, these are valves attached to your great vessels. And what are the great vessels? We have your aortic and the pulmonary. So we name them according to their attachment. So a semilunar valve attached to your pulmonary area, pulmonary is what we call pulmonary semilunar. A semilunar valve attached to your aorta is what we call aortic semilunar valve. Okay? So again, you have the AV valve and semilunar. Here's the picture. Where is it? There. So this is actually the superior vena cava. I hope you can see this one. Let me check. Can you see when I move the cursor? I hope so. So this is the superior vena cava or superior vena cava. Hold on. How can I do that? I want to make it sure that I can write. Hey, where is it? Nawala siya. Nawala. Anyway. Hey, I want to write. Let's choose a different color. Okay, let's choose black. Ay, ba't ayaw niya magsulat? Oh, here. So this is the superior vena cava. Okay, natin. Superior vena... Hey, what's wrong? Ayaw gumana or hindi lang talaga ako marunong. Anyway, I hope you can see as I move the cursor. So this is the superior vena cava. Inferior vena cava, this is the right atrium. Right atrium. Let me see if nakikita niyo gumagalaw. Yeah. Nakikita niyo gumagalaw yung cursor. So this is the right atrium, this is the right ventricle. This valve here is your tricuspid, which is a form of an AV valve. Okay? This is the septum I'm talking about. This is the left atrium and the left ventricle. There's another valve here. We call this as your mitral or bicuspid valve. So these two are what we call AV valves. And guess what? What's so important about this is that when these two valves close, okay, when these two valves close, they create a sound, okay? And you call that heart sound as your S1 or lob. S1 or lob. So if you can see me, I hope so. So when these two valves close, when they close, they give you a sound, lob, 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 or S1. So S1 or lob is a normal heart sound, okay? S1 or lob is a normal heart sound, and that heart sound or lob or S1 is brought about by closure of the AV valves. Okay, so take note. Heart sound is brought about by valvular closure. We're talking about the normal heart sound, okay? Lob or S1. And these two here are what we call semilunar. So this is the pulmonary trunk. There's a valve attached to that area, and that is your semilunar. We call that as your pulmonary semilunar valve. This is the arc of aorta. There's another valve attached there that's your semilunar, and we call that as your aortic semilunar. Remember, I said semilunar valves are named according to its attachment. So when these two valves again close, they create a sound, and that heart sound is your S2 or dub. Okay, dub. So lub or S1 is due to the closure of AV valves. Dub or S2 is due to the closure of your semilunar valves. Okay, let's write it down. Okay. So you have your lub, dub. They're both lub, dub. So lub is your S1, dub is your S2. So S1 is due to closure of your AV valves. Dub or S2 is due to the closure of your semi-lunar valves. Okay? So what's the point? The point here is if you have valvular problem or valvular abnormality, maybe related to what do you call this, rheumatic heart problem or a congenital abnormality. If you have a valvular problem, a valvular defect, the likelihood that you will have abnormal heart sound is very high. Chances are very high because, again, heart sound is due to closure of the valve. So that's it. Apart from that, one function of the valve is to prevent reflux or regurgitation. So if you have valvular defect, the likelihood to have regurgitation is high. That is why if you're diagnosed with valvular defect, it's important for you to have a regular echocardiogram. Your echocardiogram will evaluate degree of regurgitation or reflux. Not only that, your echocardiogram will also check if there's enlargement of the heart. Okay. Not only that, your echocardiogram will also check your ejection fraction, which is essential. And we will talk about that in a bit. Okay. So that's your heart. Okay. What else? Now let's try to run down all those structures. So again, this is what they call your superior vena cava, inferior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary semilunar valve, pulmonary trunk. These are the pulmonary arteries, the only arteries in the body that carries deoxygenated blood. These are your pulmonary veins, the only veins in the body that carry oxygenated blood. This is the left atrium. This is the mitral valve or your bicuspid valve. This is part of your left ventricle. And this is what we call the aortic semilunar valve. And this is the arc of the aorta. Okay. And by the way, if you know this strings, you call these strings as your chordae tendineae. They act as support for the valves. Now, I hope you can still remember the cardiovascular circulation. Okay. Let's try to check. If you can look at me on the left side of the screen, you can see me moving. I have in a small monitor. So blood from the head, blood from the upper extremities, part of the trunk, the deoxygenated blood goes to your superior vena cava. Blood from your part of the tummy and blood from the lower extremities will go to your inferior vena cava. Blood from the superior and inferior vena cava will meet into your right atrium. The right atrium will contract, squeezing the blood going down, opening your semilunar valve, not semilunar, opening your AV valve, particularly your tricuspid, and the blood is being pulled to your right ventricle. Once the blood is there, the right ventricle will contract, squeezing the blood up, causing opening of your pulmonary semilunar valve. Pulmonary semilunar valve opens, blood passes through there. It goes to your pulmonary trunk, to your pulmonary arteries, right and left goes to your lungs. Okay. So here's the catch. When the blood enters the pulmonary area, there's another gas exchange there. Okay. Gas exchange. And the gas exchange that is happening in the pulmonary area is what we call your external respiration. Remember, I mentioned internal respiration a while ago. Okay, so there's an external respiration happening in there. So the blood now is already oxygenated, and as a result, the pulmonary veins will collect that blood and direct that blood to the left side of the heart. That explains that the left side of the heart receives oxygenated blood. And the same principle applies. The left atrium will contract, squeezing the blood going down, opening the mitral or bicuspid valve, pulling your oxygenated blood into your left ventricle. Left ventricle contracts, squeezing the blood up, okay, passing to your mitral, okay, not mitral, passing to your aortic semilunar valve, enters to your arc of the aorta, and to be distributed in different parts of the body. That's your cardiovascular circulation, okay? So, we know that by heart, I guess so. Kasi hindi pwede na maging nurse ka that you don't know the cardiovascular circulation. So, ito yung gusto kong i-point out. So this is our heart. Okay. Superior vena cava, inferior vena cava. This is your right atrium. This is your left atrium. This is your right ventricle and then the left ventricle. So this is the right side. This is the left side. Okay. I said that the right atrium will squeeze the blood and that blood fills the right ventricle. The right ventricle now will pump the blood and that blood goes to of course, to your lungs. Okay. So what I want you to remember is this. Let's say this is your alveoli. Okay, alveoli. So this will be the capillaries, the pulmonary capillary. Now remember, when we inhale, alveoli inflates. When we exhale, alveoli deflates, right? So as you inhale, part of the alveolar membrane touches now the capillary area, okay? And that membrane that touches the capillary area is essential because that is the site of gas exchange. In short, it is not the entire alveoli that will cause gas exchange. the part of the alveoli that touches the membrane, and you call that as your ACM. What is ACM? Alveolar capillary membrane. Okay, so there is exchange of gases. So oxygen, okay, goes to your blood. In exchange, carbon dioxide is being released. So there's exchange of gases here. You call this type of gas exchange, I mentioned that as your external respiration. So the type of respiration or gas exchange happening in the pulmonary area is your external. But in the blood to your tissues, to your cell, you call that as your internal respiration. So that is why when it leaves this area, it is now a blood rich in oxygen. So pag rich in oxygen na siya, so didiretso na siya ngayon sa left side ng heart. That is why I said that the left side receives oxygenated blood. Okay, so same principle applies. It goes to your left atrium. It passes your mitral valve. It fills the left ventricle, and the left ventricle will pump blood going to your systemic circulation. Okay, systemic circulation. Now, what I want to emphasize now are these terminologies. Okay, so we have here your, I hope you can still recall this, the preload. Are you familiar with this? Yes, sir, I heard that. We have the preload, we have the afterload, we have the stroke volume, and we also have here your cardiac output. Oh, di ba, taray? So let's discuss them one by one. What is preload? Preload is the blood, the amount of blood that enters the ventricle, that enters the heart during diastole or diastole. Okay, so that's the amount of blood, okay, that enters the heart, okay, enters the heart, that fills the ventricle during diastole. That's your preload. When you say afterload, afterload technically is the pressure or the resistance that the heart needs to overcome to pump the blood out. Again, afterload refers to the resistance that the heart needs to overcome to pump the blood out. Okay? Expound. Remember that the right ventricle will pump blood going to your lungs. Okay? So in order for this right ventricle to pump the blood out, this right ventricle needs to overcome the pressure outside. Okay? Needs to overcome the pressure in the pulmonary area. If the pressure is so high in the pulmonary area, then that will increase the workload of the right ventricle because it needs to overcome the pressure in order for blood to get out, in order for blood to get inside that compartment. So it needs to overcome the resistance, needs to overcome the pressure. So that is what they call the afterload. And what is the usual pressure? What is the usual pressure that the right ventricle will overcome? Usually it's about 20 millimeters mercury. Okay, 20 millimeters mercury. And same thing here on the left side of the heart, the left ventricle will pump the blood going to your systemic area. Okay, same thing. The left ventricle needs to overcome the pressure or resistance in the systemic area. That explains, nurses, if you have a long-standing hypertension, the vascular resistance increases. As a result, it increases the workload of the left ventricle. So what is the usual pressure that the left ventricle needs to overcome? Okay, remember your diastolic pressure, that is your 80 millimeters mercury. Okay, so that's the thing you need to remember in your mind. In order for the blood to get out from the heart needs to overcome the pressure. So there is a pressure that the heart needs to overcome in the lungs in order for that blood from the right ventricle to get out and gets inside the pulmonary area. And there is also another pressure that the left ventricle needs to overcome in order for the blood to go to the systemic area. Now, two different afterloads to consider. Now, here's the problem. If a patient has a COPD, okay, COPD, chronic obstructive pulmonary disease, which is an old name, and the new name is what we call CAL. That's your chronic airflow or chronic airway limitation. One good example of your COPD here is bronchitis. Okay, so there is what we call inflammation on the bronchial area. As a result, okay, one effect is that it causes pulmonary vasoconstriction. So the pulmonary vessels are constricted. So if the vessels in the pulmonary area are constricted, it narrows the lumen, it narrows the opening, it narrows the vessel. Blood flow is affected, right? It affects the blood flow. The pressure increases. There's increased vascular resistance. As a result, the right ventricle now increases its workload. It will increase the workload to push the blood to get inside the lungs because the blood vessels in the lungs are constricted. It increases the workload because this right ventricle needs to overcome that increasing vascular pressure or vascular resistance. What's the effect? The effect there is it will eventually cause enlargement of the right ventricle. So this will result to right ventricular hypertrophy. Okay. Now, if you read the book, some will say that this right ventricular hypertrophy, if related to pulmonary in origin or pulmonary cause, we call that condition as corpulmonale or cor pulmonale. So what is cor pulmonale or cor pulmonale? Cor pulmonale, some would say cor pulmonale, some will say cor pulmonale. I don't care. Okay, cor pulmonale or cor pulmonale refers to enlargement of the right ventricle due to pulmonary problem. And the best way to correct this issue, to correct this problem, is to treat, of course, the underlying cause. One common cause there is your COPD, especially your bronchitis. That is why in your NCLEX, if you'll be asked what common type of COPD can cause enlargement of the heart, your answer is bronchitis. Okay, and when you will see that there is right ventricular hypertrophy, you can see RVH in your EKG. Okay, you can see RVH in your two-dimensional echocardiography. You can see RVH in your chest X-ray. Remember, your chest X-ray will not only evaluate pulmonary area, it will also check the condition and the size of the heart. Okay, so makikita natin yon sa mga ganong klaseng tests. Okay, so we know if sooner or later you will encounter in the hospital that there's enlargement of the right ventricle, you suspect, oh, probably patient has a COPD or patient has an underlying pulmonary issue. Okay, now what about for the left ventricle? Left ventricle, again, I said, needs to overcome the pressure in the systemic area. If you are hypertensive and you are not taking religiously your anti-hypertensive medication, okay, so a long-standing blood pressure elevation or a long-standing hypertension would increase the vascular resistance. That is why it increases the workload of the left ventricle, resulting to left ventricular hypertrophy or left ventricular enlargement. So if you happen to see in the x-ray of the patient that the left ventricle is increasing its size, or in the EKG there's left ventricular hypertrophy, or in the echocardiogram there's left ventricular hypertrophy, you suspect that there is increase in the vascular resistance. The hypertrophy here is actually related to compensation and an effect because of increased workload. Remember, any muscle in the body, okay, any muscle, not actually not all muscle, okay, but most muscles, if they overwork, okay, they increase its size. We call that as your hypertrophy. And it also follows that if you don't use the muscle, they tend to shrink. We call that as your atrophy, or yeah, atrophy. That is why if you are very keen, if you have a patient who has a fracture and end up uh putting cast, or you immobilize the affected part, ano napansin nyo? If you immobilize an affected body part, you will notice that that area will shrink because you don't use that. It will atrophy. And we call that type of atrophy as disused atrophy. Okay? Because you don't use that. So it will shrink. It will decrease its size. So anything na ginagamit, lumalaki. Hindi ginagamit, lumiliit. Parang ang sagwa, ano? Anyway, so you have that, you have there your left ventricular and your right ventricular hypertrophy. By the way, how will you know that there is a right ventricular hypertrophy in your EKG? And how will you know that there is left ventricular hypertrophy in your EKG? Anyway, we don't do, nurses don't do this actually. We don't diagnose patient. Doctors will do that. But para malaman nyo lang, you check the 12-lead EKG of your patient and you check V1. You check V1. V1. Okay, remember there are 12 leads. You check V1. Ideally, for example, ito yung V1, P, Q, R, S, P. Okay, so this is your P wave. This is your Q. This is your R. this is your S, this is your T. Ideally in V1, if this is your isoelectric line, the R wave is short, but the S wave with respect to your R wave using your isoelectric line is tall. But if your R wave is taller, okay, R wave is taller than your S wave, like that, R wave is taller than your S wave, you suspect right ventricular hypertrophy or right ventricular enlargement. So you check the V1. How will you know if it is left ventricular hypertrophy? You check again the V1 and you check V5. Others, they use V6. So what are you going to do with V1? You measure the height of S wave in V1 and R wave in V5. So if this is your isoelectric line, you check what is the height of S wave in V1, you count how many millimeters, and then you count how many millimeters R wave in your V5, okay? And you add them. If the sum of S wave in V1 and R wave in V5 is equal or greater than 35 millimeters, you suspect left ventricular hypertrophy or left ventricular enlargement. Okay, you suspect left ventricular hypertrophy or left ventricular enlargement. How many boxes are there when you talk about 35 millimeters? That's 35 small boxes. Okay, remember, one big box has 5 small boxes. So you will have 35 small boxes, equal or greater than 35. Anyway, nangyari sa buko. Okay, so having said that, if your patient is hypertensive, tell them you have to take your antihypertensive medication religiously. Based on research and studies, if the patient is taking his or her antihypertensive medication religiously, it will prolong the life, okay, of the person. Okay, because uncontrolled hypertension is not good. It will increase your likelihood to have stroke, heart attack, kidney failure, and a lot more. Okay, so anyway, so we're done with the preload. We're done with the afterload. Now, what is stroke volume? Stroke volume is actually the amount of blood every time the heart beats, every time the heart contracts. So if the heart contracts, it pumps the blood out. Okay, the amount of blood ejected every time the heart contracts, that's your stroke volume. Okay, so this will be ml every beat. Okay, every beat. So that's the amount of blood ejected every time the heart contracts. And the average stroke volume is about 70 ml. That's the average. Okay. And what about cardiac output? The cardiac output is the product of heart rate and stroke volume. Okay, heart rate times stroke volume. In short, cardiac output is the amount of blood ejected in 1 minute. Okay, in 1 minute or in every minute. Okay, in every minute. Kasi nga, that's the heart rate times stroke volume, and stroke volume is ml per beat. So cardiac output is the amount of blood ejected every minute. Okay, every minute. So that's the key. That's the product of heart rate times stroke volume. Now, what I want to emphasize here is that ideally, if you look at the technical side, if you do the math, the higher the heart rate would mean the higher the cardiac output. Correct? Kasi nga, that's the product of heart rate and stroke volume, but it doesn't happen always. Now, why? Especially if you have a sustained tachycardia. Usually, why? Because sa sobrang bilis ng tibok ng puso, pag sustained siya, let's say more than 115 beats per minute, greater than 115 beats per minute sustained. Pag masyadong mabilis ang tibok ng puso, if the heart beats so fast, it will decrease, okay, the ventricular filling time. Okay, it will not give the heart of the patient an ample time to fill it with blood. Okay, so as a result, if the heart beats so fast, okay, it will only eject small part of blood because of decreased ventricular filling time. Okay, so hindi rin siya maganda. Okay, I hope that is clear. So I think I explained preload, afterload, stroke volume, and cardiac output. If you have any questions, let me know. Let me check if you have any questions. Let's see. Okay. Now, there are medications when you give to your patient will affect heart rate, will affect contractility of the heart. Okay. And I usually discuss that in the actual review program. Next. Okay. Here. I want to emphasize this one. I said that when the heart contracts, it pumps the blood out, and the blood enters a closed circuit from the heart. It passes to different chambers, and then the valves open. When the valves open, blood passes through there. When the valves close, I said it creates a heart sound. Okay. And I said heart sounds are due to closure of the valves. Lub, dub, lub, or S1 is due to the closure of your AV valve. Dub or S2 is due to the closure of your semilunar valve. Now, one of the most important nursing responsibility is to assess or listen to heart sounds. So these are 5 areas that you have to uh, assess, that you need to listen if you have a patient. Okay. So your mnemonic here is all people enjoy Time Magazine. I don't own this mnemonic, so credit to whoever formulated this tip. And I don't own this picture as well. I saw this sa internet, so credit to its what do you call this owner. I have a 2007 Nursing Education Consultants INC. So copyright. So this is the rib cage. This is the sternum, xiphoid process. If you want to listen to your aortic valve, okay, aortic valve, you place your stethoscope on the right sternal border on the second intercostal space. Okay. If you want to listen to your pulmonary valve, okay, you place your stethoscope on the left sternal border on the second intercostal space. Now remember, pulmonary semilunar valve and aortic semilunar valves are examples of semilunar valves, and semilunar valves can cause dub or S2 heart sound. So what is the point? The point here is if you place your stethoscope on this side, okay, on this side, you will hear a loud S2 sound than S1, okay? You will hear a loud S2 sound than S1. This is the Erb's point. This is the halfway of the heart. This, you place your stethoscope on this side if you want to check for tricuspid valve, if it's on the left sternal border on the fourth intercostal space. If you want to listen to your mitral valve, you put your stethoscope on the left fifth intercostal space on the mid-clavicular line. Remember, tricuspid valve and mitral valves are examples of your AV valves. And once AV valves close, they give you lub or S1 sound. So having said that, if you place your stethoscope here on this area, you will hear a loud S1 sound compared to S2. So ganito yon. If you place your stethoscope here, okay, on the base, okay, base of the heart, remember, if you position your heart this way, the base is on this side, the apex is nasa baba. If you place your stethoscope here, you will hear a loud S2 sound. Dub, 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 dub. I don't know if that makes sense. Okay, mas malakas yung dub S2 compared sa lub. But if you place your stethoscope on this area, okay, in the apex area, because that is where your AV valves are, okay, na maririnig yung sounds nila, if you place your stethoscope here, you will get a very loud, prominent S1 or lub sound than S2. Lub, dub, lub, dub, lub, dub. I hope that makes sense. Okay, so in short, if you place your stethoscope on the base of the heart, you will hear a prominent and a loud S2 sound. If you place your stethoscope on the apex of the heart, you will hear a loud or a more prominent lub or S1 sound compared to your S2. Why? Because of those placements. Okay, so again, your mnemonic here will be all people enjoy Time magazine. Okay, next, what I want to talk about now is your conduction system. Now, I really want you to know this by heart, store this in your cerebrum because this is the foundation of your electrocardiography. Okay, so this is your SA node. Okay, your SA node is here on the superior aspect of the right atrium near the opening. Your SA, the sinoatrial node, that is considered to be the pacemaker of the heart, right? Now, why do we call it pacemaker? Because it will set the pacing, it will set the rhythm, the pacing of the heart. Now, your SA node is programmed to deliver fire a heart rate ranging from 60 to 100. 60 to 100. More than 100, that's tachycardia. Less than 60, that's your bradycardia. Okay? Now, this is what we call the AV node or the atrioventricular node. Okay? Your AV node is also programmed to deliver a heart rate ranging from 40 to 60 beats per minute. 40 to 60 beats per minute. This is what we call the bundle of His. Okay, bundle of His. This will be your right branch, left branch, and the Purkinje fibers. Purkinje fibers. Okay, so that will be the direction of your impulse transmission, and I will explain that later. So SA node, AV node, bundle of His, right branch, left branch, Purkinje fibers, Purkinje fibers. I hope that's clear. Now, please allow me to write something on the board. Kasi ito yung magiging foundation natin. Here. So this is your SA node. This is your AV node. This is the bundle of His. This is the right branch. This is the left branch. Purkinje fibers, Purkinje fibers. So SA node, this is your AV node, okay? This is the bundle of His. These are the right and left branches, and these are your Purkinje fibers. Okay. As mentioned, the SA node can deliver a heart rate ranging from 60 to 100 beats per minute. Your AV can deliver a heart rate ranging from 40 to 60 beats per minute. Okay. And of course, in the ventricular area, there are what we call ventricular area. There is what we call ectopic foci. They can deliver a heart rate ranging from 20 to 40 beats per minute. Okay, now, the pacemaker is what we call the SA node. If something went wrong with your SA node, don't worry, you have a backup system, and that's your AV node. Okay? Once the AV node malfunctioned, then you have the ventricular area. Problem here, it will set 20 to 40 beats per minute, and we don't live at 20 beats per minute. So having said that, a patient with SA node or a patient with AV node malfunctioning, then if you have that problem, SA node or AV node malfunctioning, importante ngayon ang pacemaker implantation. So pacemaker transplant or pacemaker implantation, pacemaker implantation is indicated to patient with SA node or AV node malfunctioning. And I usually discuss pacemaker implantation in the actual review. Remember, you have your asynchronous and synchronous pacemaker, temporary, permanent pacemaker. How will you know that a patient is atrial paced, ventricular paced, or AV paced? Okay, what is the tracing in the EKG that you know that a patient has a pacemaker? What are your nursing responsibilities to a patient with pacemaker? What are activities that you need to avoid if you have pacemaker? All those stuff will be discussed in the actual review program. Okay, now let's go back. So again, pacemaker is indicated to patient with SA-AV node malfunctioning. Now here, once SA node is stimulated, okay, the SA node will release an electric current. It releases an action potential. Okay, some book they call it electric current. Some book they call it action potential. And that action potential or electric current will travel from the SA node, then it goes to your AV node. Okay, the AV node will get the action potential, will get the electric current, and it directs that electric current to your bundle of His. Once it reaches the bundle of His, it will distribute the electric current to your right branch, okay, to the right branch and to the left branch. And then electric current will travel down now to your Purkinje fibers. Okay, that's the conduction system. That's the conduction pathway from the SA node to AV node to bundle of His to right and left branches down to your Purkinje fibers. That is the pathway of the conduction system. Okay, don't forget that. Now, here's the heart. Here's the placement. SA node, AV node, bundle of His, right branch, left branch, Purkinje fibers, Purkinje fibers. Hold on, I will change the color. Okay, so this is the SA node. This is the AV node. This is the bundle of His, the right branch, the left branch, and the Purkinje fibers. Okay. This is your superior vena cava, inferior vena cava. Okay, here, I want you to listen carefully. Blood enters your superior inferior vena cava, enters your right atrium. Once SA node is stimulated, it causes electrical impulse, right? Generation. And as a result, it can cause contraction of the right and left atrium. As the right and left atrium contract, okay, that electrical impulse will travel and goes to your SA node. The SA node will get the electric impulse, the action potential, or the electric current, and then it traveled to your bundle of His, right and left branches down to your Purkinje fibers. So technically, the impulse will travel from this part going down. Since the impulse traveled going down, there's no more impulse on top. As a result, the atria now will relax. The impulse is here in the ventricular area. So the ventricle area now will contract, right? So as the ventricles contract, the right ventricle will contract, it pumps the blood to your lungs. The left ventricle will contract, okay? The blood now is ejected and it goes to your systemic circulation. So it's all because of the electrical activity in the heart. And that electrical activity traveled from the SA node to AV node, bundle of His, right and left branches, Purkinje fibers. Okay? Okay. Now, I want you to look at me and look at the scenario. So may nag-comment. Can you hear me now? Sir, nawala sounds po. Are you sure you cannot hear me? Can you hear me now? Please let me know if you cannot hear me. Hey, sound check. Hey, sound check. Yeah, I can hear myself. Okay. So this is your heart, the right and left atrium, and the right and left ventricle. Okay. Once the SA node is stimulated, it can cause contraction of the right and left atrium. As the atria contract, the impulse will travel going down. Okay. So the impulse will travel from the SA node to AV node, bundle of His, right left branches down to your Purkinje fibers. So the impulse will travel from the base down to the apex of the heart. It goes down. So the impulse is already here. There's normal impulse on top. As a result, the atria will relax, the ventricles will contract. Why ventricles contract? Because the impulse is there. Why the atria relax? Because there's no more impulse there. The impulse traveled going down. So technically, yun yung nangyayari. Okay? So again, right and left atrium, right and left ventricle. Back. Once stimulated, once SA node is stimulated, it can cause contraction on the right and left atrium. As the atria contract, the impulse will travel going down from the base down to your apex. From the SA node to AV node, bundle of His, right and left branches, Purkinje fibers. So once the impulse is here in the ventricular area, the atria will relax. Okay? Once the impulse is here, the ventricles will contract. Okay? After ventricles contract, it will relax. Okay? All because of electrical activities going on inside the heart. And guess what? Those electrical activities going on inside the heart can be recorded, okay, in a test called EKG or electrocardiography. So when you say electrocardiography, it is a test that records electrical activities in the heart. And those electrical activities are graphically presented. Okay? So common sense will tell us that the EKG or ECG will not record contraction because that is the common mistake of nurses that EKG records contraction. No, your EKG will not record contraction. It records electrical activities going on inside the heart. And those electrical activities are actually represented as waves. So we have the P wave, we have the QRS complex, and the T wave. Okay, let's write it down. So we have the P wave. We have your QRS complex. Then we have your T wave. P wave represents atrial depolarization. Your QRS represents two things. It represents atrial repolarization and ventricular depolarization. T wave represents ventricular repolarization. Sir, I know that. I memorized that concept. I just don't understand what is depo, what is repo, what is depo, what is repo. We're talking about depolarization. I am not talking about depo-provera, which is a form of contraceptive. Okay? So depolarization, if you discuss this in detail, there is what we call movement of sodium ions. Okay, but we will just simplify that. Let's get rid of the technicalities. So to make it simple, when you say P wave atrial depolarization, you say depolarization as stimulated, just to make it simple. Okay, just for you to easily understand the concept. Okay, but generally, when you say depolarization, it talks about the movement of your sodium ions. Sodium is a positively charged electrolyte. Repolarization, to make it simple, just for you to easily understand the concept, let's say this is the resting phase. Depo, let's say this is a stimulated phase area. Repo, let's say this is the resting. Okay, remember, I am using these terminologies for you to easily understand the concept. Okay, so let's just say that depo is stimulated, repo is resting, depo again is stimulated, repo again is resting. So the P wave represents stimulation of the atria. QRS represents resting of the atria, stimulation of the ventricles, and T wave represents resting of the ventricles. Okay, simple as that. Okay, balik. So here, right and left atrium, right and left ventricle. Let's try to review the conduction system, the pathway. and we will incorporate these waves. So right and left atrium, right and left ventricle. What did I tell you? Once the SA node is stimulated, it can cause contraction of the right and left atrium. As the atria contracts, the impulse will travel going down. Remember, the movement will be from the base down to the apex. The impulse will travel going down, specifically from the SA node to AV node, bundle of His, right and left branches, Purkinje fibers. Impulse will travel going down, therefore atria will relax, ventricles will contract. After ventricles contract, they will relax. That's the basic scenario. That's the activity. Let's correlate that with the different waves. Okay. So right and left atrium, right and left ventricle. Look, once stimulated, okay, once as a node is stimulated, it can cause contraction of the right and left atrium. Mas stimulate siya. So this is what we call P wave, atrial depolarization, P wave, stimulation. As the right and left atria contract, the impulse will travel going down. When the impulse is in the lower part, in the apex of the heart, the atria will relax, the ventricles will contract. This is what we call QRS complex, atrial resting ventricular stimulation. In short, atrial repolarization, ventricular depolarization. QRS complex. And after the ventricles contract, the ventricles will relax. This is your T wave, ventricular repolarization. So P wave, QRS complex, T wave. P wave, atrial depolarization, QRS complex, atrial repolarization, and ventricular depolarization. That is your QRS complex, and the last T wave, ventricular repolarization. Therefore, P, QRS, T is one heartbeat. Okay, P, QRS, T, P, QRS, T, P, QRS, T, P, QRS, T. Simple. Okay, that is why in your ECG tracing tonight, okay, because this is just an overview. Remember, I said there are two parts of this streaming. Part one tonight. Okay, what we're doing right now is an introduction, and then the actual EKG will be tonight. PQRST. Okay, so in short, if you want to read the EKG and you want to know if there is something wrong with the atrium of the patient, you check the P wave. Why will you check the P wave? Because the P wave will represent the activity of the atria. If you want to know if there's something wrong with the ventricles of the patient, you check the QRS complex. Why QRS complex? Because again, the QRS complex will represent the activity of the ventricles. Okay, I hope that is clear. So you have the PQRST, PQRST. So don't forget the P wave. What time tonight po? I think 7 o'clock or 8 o'clock p.m. my time, Central Standard Time. Okay, so PQRST, PQRST. Okay, so again, if you want to check the standing of the atrium, you check the P wave. If you want to evaluate the ventricles of the patient, you check the QRS complex. Okay, and that's it. So again, two sides, bago ko makalimutan, right side of the heart, left side of the heart. And by the way, one parameter to check the right side of the heart functioning is to check the CVP or the central venous pressure. Okay, the CVP will evaluate right side of the heart functioning. What about on the left side of the heart? If you want to check the left side of the heart functioning, one parameter, one test we use is the PCWP. We call that your pulmonary capillary wedge pressure, PCWP. So again, your PCWP will evaluate left side of the heart. Your CVP will evaluate right side of the heart. Okay, so I hope that is clear. Next, another thing I want to talk about is the ECG strip. So this is your ECG strip. This is your ECG strip. Your ECG strip is composed of small boxes. There are small boxes here and the big box. Don't forget the big box, the borders of the big box are always darkened. Okay? So we have one small box and we have a one big box. Again, the borders of the big box are always darkened. How many small boxes are there inside one big box? There are 5 small boxes. So look, if this is one big box, 1, 2, 3, 4, 5. one small box, okay, and one big box. Okay, don't forget that. And on top, if you can see this grid here, there's a line. Okay, line from this area and another line. This will be your 3 seconds. 3 seconds. So if you measure this part going here, that will be your 6 seconds. So we have this what you call 6 second strip. Okay, tingnan mo na lang itong linya-linya na ito. So from one line to another line, 3 seconds. So this will be a 6 second strip. Okay? Now what else? Another thing. Anyway, ibabalik ko to mamaya. Here. This is important. So this is your ECG strip. I said there are small boxes and a big box. Okay, now take note. One small box is equivalent to 0.04 second. Remember, I said 0.04, not 0.4. Magkaiba ang 0.4 sa 0.04. Okay, so one small box is 0.04 second. Two small boxes will be what? 0.08. Three small boxes will be 0.12. Okay, remember one small box is 0.04. One big box has 5 small boxes. Therefore, how many seconds are second on one big box? You just have to multiply 0.04 times 5. What is the what is the product? The product is 0.20. So take note, one small box is 0.04 second, one big box is 0.20 second. There are 5 small boxes in one big box, and the borders of the big box are always darkened. Okay? And look at the different waves here. So this is the P wave, atrial depth polarization. This is your QRS complex, atrial repolarization, ventricular depolarization. And this is your T wave, ventricular repolarization. Please be reminded that there is one P wave before QRS complex, and there is one T wave after QRS complex. And after T wave, it is followed by P wave. Okay? P, QRS, T. P, QRS, T. Okay? Don't forget that. Look at the normal heart rate. So the normal heart rate is 60 to 100 beats per minute. I said that. The normal PR interval, this is the PR interval. So remember, there are small boxes here. There are 3 small boxes. So the normal PR interval ranges from 0.12 to 0.20 seconds. So how many boxes will that be? That will be 3 to 5 small boxes. Don't forget that. 3 to 5 small boxes. That's the normal PR interval. If you have a prolonged PR interval, okay, you suspect AV block. Okay, you suspect AV block. So a prolonged PR interval, normal PR interval, 3 to 5 small boxes. Next, QRS complex. So this is your QRS complex, beginning of the QRS complex, okay, and the end of your QRS complex. That's your QRS complex. So the new normal QRS complex is 0.08 to 0.12. So how many boxes will that be? That will be 2 to 3 small boxes. 2 to 3 small boxes. Please don't confuse yourself with the big box and the small box. Remember, this is a small box. This is a big box. So we're talking about 2 to 3 small boxes for your QRS complex and 3 to 5 small boxes for the PR interval. Okay? Please do not forget this. Big box, borders are always darkened. Don't forget that. One big box has 5 small boxes. And by the way, one small box, 1 mm, 1 millimeter. Two small boxes, 2 millimeters. One big box, 5 millimeters. Why 5? Because there are 5 small boxes, and one small box is 1 millimeter. I hope that is clear. Sir, do you have a lecture on diabetes? Yes, I have. We can do that after this if you want. Okay? So I hope this is clear. I hope this is clear. So please don't forget this concept. This is an introduction of your basic EKG. Okay? So do you have any questions? I hope you learned something, guys. So part two will be tonight at 8 o'clock or 7 o'clock Central Standard Time. Okay, Raquel de Castro, do you have a lecture on diabetes? Yes, I do. What specific uh, topic in diabetes you want me to talk about? Raquel, what specific topic in diabetes you want me to talk about? Let's wait for her response. Thanks, Raquel. Tell me what specific topic in diabetes you want me to talk about. DM type 1, DM type 2. Okay. Okay, we can talk about it ngayon. Okay, so may request DM type 1, DM type 2 complications and treatment. This is your request, Raquel de Castro. So let's talk about that. But please don't forget part 2 of your EKG reading tonight. Okay? Okay, so there's a request here, diabetes mellitus type 1, type 2 complications and treatment. So what is diabetes mellitus? By definition, diabetes mellitus is a chronic metabolic condition characterized by hyperglycemia due to a defect in insulin production, insulin action, or both. Okay? So ulitin natin. Diabetes mellitus is a chronic metabolic condition characterized by hyperglycemia due to a defect in the insulin production, insulin action, or both. So technically, in diabetes mellitus, ang issue dito is insulin. Remember, insulin serves as a key, okay, so that okay, sugar or glucose can get inside the cell. There's a need for the sugar to get inside the cell because sugar is a form of energy, okay? So actually, there are different types of diabetes mellitus. Okay, there are different types of diabetes mellitus. Iba-iba yung mga types niya, ano, mga categories nila. But usually when I give my lecture, I only divide diabetes mellitus into three. Your type 1, your type 2, and gestational diabetes. Okay? Type 1, type 2, and gestational diabetes. So let's try to differentiate these types of diabetes mellitus. Where's my whiteboard? Whiteboard here. Where is that? Okay. So, your diabetes mellitus. So, diabetes mellitus, as mentioned, by definition of, kaya nakuha yung definition na yon. Para nakuha ko siya sa book ni, yung volume 1, volume 2, na makapal na color green dati. Nung panahon ko, color green pa yung cover niya. Okay? Volume 1, volume 2. Nakalimutan ko yung author niya. It's not Lippincott. Brunner Sudarth. Okay? Brunner Sudarth, Medical Surgical Nursing, Brunner Sudarth. I also used the book of Black, the Medical Surgical Nursing. I also use pathophysiology book na for my lectures. Okay, so diabetes mellitus is a chronic metabolic condition characterized by hyperglycemia due to a defect in insulin action or insulin production or both. Okay, so there are three common types of diabetes, as I said, type 1, type 2, and gestational. But usually didn't discuss yung dalawa kasi yung gestational diabetes, I leave that concept sa OB instructor. So pag nag-discussion ng OB nursing. So ano yung difference ng type 1, type 2? Type 1, and then you have your type 2 diabetes. Nag-discuss na sa Rika. Nakala ko EKG lang i-discuss ko. Anyway, burahin natin. May sulat ako dito. Hey, what's wrong? Okay. So number one, look at the difference. In type 1, look at the incidence, occurrence. Type 1 is about 5 to 10% of diabetic people, of diabetic patients, diabetic cases. Type 2 is about 90 to 95% of diabetic people. In short, there's a lot of type 2 diabetic than type 1. Okay, so again, there's a lot of type 2 diabetic than type 1. Next, onset. Type 1 usually younger than 25 years old. So this is common sa mga bata. Type 2 usually happens sa mga obese and older than 25. Other book older than 30. Depends what book are you using. Next, number 3, type 1 diabetes has several names. Okay? Type 1 diabetes is also called your juvenile onset diabetes. Type 2 is also called adult onset diabetes. What else? Your type 1 is also called ketosis prone diabetes. Type 2 is what we call ketosis resistant diabetes. Okay? Type 1, you also call this as your brittle diabetes. Type 2, you call this as your stable diabetes. Okay? Next, number 4. Number 4. Look at the common problem or common issue. The common issue for type 1 is your DKA. DKA stands for diabetic ketoacidosis. So DKA or diabetic ketoacidosis is common to type 1 than type 2. What's the common issue or problem for type 2 is your HHNK. And this stands for hyperglycemic hyperosmolar non-ketosis. Now, how do we treat patient with type 1? Of course, we have dietary modification. We do recommend exercise, okay? And we also do here insulin. Now, remember, your dietary modification is important. Exercise is very important. Why? Your exercise will help decrease your blood sugar level. Your exercise will also decrease the risk of having cardiovascular complications. And we also give insulin, okay? For your type 2, we also do dietary modification. We also do exercise, okay? And we also do insulin, okay? Remember, if the sugar level of patient with type 2 is not well regulated, sometimes we give insulin. And we also do OHA. What is OHA? Your oral hypoglycemic agent, okay? So insulin is different from OHA, your oral hypoglycemic agent. Your oral hypoglycemic agent, just like your metformin, your glucophage, okay? Your oral hypoglycemic agent, the action of this medication is to stimulate the pancreas to produce insulin. So if you look on in bird's eye view, in your type 1, you still have a little function of your pancreas. Okay? You still have a little function of your pancreas, but in your type 2, there's none. That is why we do give insulin to your patient. That is why an old description of type 1 is your IDDM. For type 2 is your NIDDM, but we no longer use that nowadays. Why? If you keep on using IDDM and IDDM, and time will come that you have to give insulin to patient with type 2, patient will refuse. Why will you give me insulin? You said that I am a non-insulin dependent diabetes mellitus. See, remember I said there are times that we give insulin to patient. So if you keep on using that terminology or those terminologies, eventually in the future, you may end up having difficulty treating patient. So we no longer use the terms IDDM and IDDM. We use type 1, type 2. Okay? So that's it. Next. So ano ba yung scenario? Well, let's try to simplify. Let's try to simplify diabetes mellitus. We know pancreas, correct? Your pancreas is both endocrine. Nag-discuss ako ng anatomy, pero nauna yung definition ko ng diabetes. Mali. Dapat inuna ko yung anatomy bago ako nag-discuss ng sakit. But anyway, is both endocrine and exocrine structure. Now let's start with an exocrine gland. Pancreas as an exocrine structure is that the pancreas produces pancreatic. It produces pancreatic juice. And guess what? What? Okay. The pancreatic juice produced by the pancreas contains enzymes. Okay. And these are what we call pancreatic enzymes. Okay. And what are these enzymes I'm talking about? I'm not talking about SGPT, okay, because those are liver enzymes. We're talking about pancreatic enzymes. So what are this? We're talking about amylase, and I'm talking about lipase. These enzymes, amylase and lipase, are essential for what we call digestion. Digestion refers to breaking down into its simpler form. Your amylase is important for carbohydrate digestion. Lipase, on the other hand, is important for lipids or fat digestion. Diba? Taray. Kaya nga pag may problema ka sa pancreas at wala kang pancreatic juice, magkakaroon ka ng indigestion of these substances. Hindi na dadigest yung fats. If we fail to digest the fats will go to your stool. So one manifestation of the patient is fat in the stool. We call that as steatorrhea. So can we correct that? Yes, we can correct that. You can give pancreatic enzyme supplement. Okay. So that is one common question in the NCLEX. I forgot to tell you that. So how often you give pancreatic enzyme? We give that to your patient every time the patient eats. So if the patient will have 6 times a day, 6 meals per day, then we give pancreatic supplement 6 times as well. So every time the patient eats, you give pancreatic enzyme. Anyway, that's the exocrine function. What I want to focus is the endocrine function of your pancreas. Okay, we're talking about the islets of Langerhans of your pancreas. Islets of Langerhans. There are 2 primary cells. Actually, tatlo yung cells dito. But I will just discuss this too. What are the 2 primary cells in the islets of Langerhans of the pancreas? We have this alpha cell and the beta cell. Your alpha cell will produce glucagon. Okay. Your beta cells will produce insulin. Okay. The glucagon will increase your blood sugar. Okay. The insulin is the opposite of your glucagon. It decreases your blood sugar. That is why if the patient is hypoglycemic, pag mababa yung blood sugar ng pasyente, we can give glucagon and that will increase the patient's blood sugar. Okay? Now, in your diabetes mellitus, I said by definition, it is a chronic metabolic condition causing hyperglycemia due to a defect in insulin production, insulin action, or both action and production problem. Okay? Now, to make it simple, let's say this is your blood vessel. Okay, and these are your cells. Just an example. Okay, just an example. So you have a lot of glucose inside the blood vessel. So you have your hyperglycemia. So if you're hyperglycemic, it stimulates the pancreas to release a hormone called insulin. Insulin is released in order to decrease the blood sugar. How can insulin decrease the blood sugar? To make it simple, let's simplify the topic. The insulin, okay, your insulin serves as a key. Please bear with my drawing. Ang sagwa ng drawing, but that's a key. And the cell wall, let's say these are doors. Okay? So what will insulin do is that insulin opens the cell wall so that sugar can get inside. Okay? So that's the action of your insulin. And guess what? In order for that insulin to work as a key, insulin must carry two things. Okay? Insulin must carry two things. And what are these? Insulin needs to carry sugar and insulin needs to carry potassium. So if both hands carry something, potassium and sugar, insulin can work as a key, opening the cell wall and dumping sugar inside the cell and potassium inside the cell. Why will potassium get inside the cell? Because if you can still remember your PISO, potassium in, sodium out. If this is your cell, the most abundant electrolyte inside the cell is potassium, and the most abundant electrolyte outside the cell is sodium. Potassium inside, sodium outside. By the way, PISO will be the placement of these electrolytes, and these electrolytes are cation. When you say cation, they are positively charged. So again, insulin opens the cell wall so that sugar can get inside. Okay? Now, why is it important for sugar to get inside the cell? Because sugar is a form of energy. So look at your diabetes mellitus. If you have diabetes mellitus, if you don't have insulin or problem with insulin, nobody opens the cell wall. As a result, sugar stays in the bloodstream. That is why if sugar stays in the bloodstream, that will increase its level, causing hyperglycemia. And that is in our definition. Okay, diabetes mellitus is a chronic metabolic condition characterized by hyperglycemia. So there's hyperglycemia. So question, if sugar cannot get inside the cell, cell doesn't have energy, correct? So what will happen now if you don't have energy? These cells will find ways or means to get energy. So if they cannot get energy out of carbohydrate, remember in your biochemistry, if you're familiar with Krebs cycle, that's how energy is being formed. If they cannot use carbohydrate, the cells now will utilize protein and fats as a form of energy, correct? Instead of using carbohydrate. So if you use protein and fat as an energy instead of carbohydrate, what do you call that condition? You call that condition as your gluconeogenesis, right? Gluconeogenesis. Gluco, that's your glucose, that's your energy. Neo, that's new. Genesis, that's beginning. Beginning of new energy. And what is the new energy source? That's your protein and fats. But ideally, you use carbohydrate as an energy. But the problem, since there's no insulin, we can use this carbohydrate. The body needs to find ways to get energy. Then that's in the form of protein and fats. Okay? Now, anyway, before I'll forget this one, insulin to work as a key needs to have carbohydrate and potassium. Don't forget this. A patient with hyperkalemia or increased blood potassium level, one management of hyperkalemia, instead of giving potassium wasting diuretic, you can also give kayexalate. It's a sodium polystyrene sulfonate. It can be given PO. It can be given enema. It's a form of an exchange resin. You can also do dialysis to patient with hyperkalemia, and you can also give insulin and glucose. Why we give insulin and glucose to patient with hyperkalemia? Because again, because of this condition, your insulin opens the cell wall and dumping potassium inside the cell, so it will correct hyperkalemia. So don't be surprised that the patient with hyperkalemia or increased blood potassium level can be treated by giving insulin and glucose. Okay. By the way, what is the normal potassium level in the blood? The normal blood potassium level ranges from 3.5 to 5.0. Other book, 3.5 to 5.5. Okay? Well, whatever. So that's it. Now let's go back. Anyway, if you have any questions, let me see. And then insulin plus glucose. Correct. Let's continue. Whiteboard. So here's the problem. So technically, or generally speaking, there is a decrease in your insulin. Correct? So a decrease in the insulin, okay, a decrease in the insulin will affect metabolism of your protein, will affect metabolism of your carbohydrate, and will affect metabolism of your fats because it's a metabolic condition. By the way, can we cure diabetes mellitus? Well, sad to say, we cannot cure diabetes mellitus, but we can control diabetes mellitus. Okay? So if you can still remember during your college years, you were taught the signs and symptoms of diabetes mellitus. I think you were taught 3 Ps. 3 Ps. Hindi po ito yung 3 Ps sa Pilipinas na ginagawa ng gobyerno natin. So I'm talking about the 3 Ps that you're familiar about diabetes mellitus, the polydipsia, polyuria, and polyphagia. That's an old, old, old concept. So what I did, I formulated another mnemonic for this. So ang ginawa ko, I added 2 more Ps. So that will give us 5 Ps. So what are the 5 Ps for patient with diabetes mellitus? So we include the 3 old Ps, the polydipsia, polyuria, polyphagia, and I added 2 more. So you will have poor wound healing and you have a profound weight loss. So these are 2 added Ps when I talk about diabetes mellitus. Okay, so anyway, you will encounter those 5 Ps in a bit. So a decrease in the insulin, okay, a decrease in the insulin will affect protein and fats. Remember, I said we use them as a form of energy. So that will result to an increase in your protein metabolism. In your carbohydrate, we don't use that because we don't have insulin. So there will be a decrease in your carbohydrate metabolism. What about fats? We use that as a form of energy. So there will be an increase in your fat metabolism. So let's begin with your protein. If we use protein as a form of energy, remember proteins are considered to be building blocks, important for repair, important for regenerations, a building block. Okay, so that's it. So if you use that, there will be an increase in your tissue wasting. Am I right? So what will happen if there's an increase in your tissue wasting? So you will have a profound weight loss. Lumabas yung unang P. Okay? Lumabas yung unang P. And guess what? Proteins are important for repair. Kaya nga, one dietary modification if you want to improve repair of your patient is to increase protein intake. Okay? So if there's increased tissue wasting, one problem will be poor wound healing. See? Lumabas ang ikalawang P. What will you do if there is increased tissue wasting? You need to replace protein loss. So you will have polyphagia or polyphagia. Kain ka ng kain pero pumapayat ka. Kain ka ng kain pero pumapayat ka. Okay? So technically yon. Remember, this is not a thorough pathophysiology. I'm just giving an overview. Now, what about a decrease in your carbohydrate metabolism? Since we don't use a sugar as a form of energy, okay, so sugar stays in the body, so you will have a condition called hyperglycemia, correct? And guess what? If you're hyperglycemic, one problem of hyperglycemia is that mangyayari ay, mamaya pala, ikokonek ko yan dito. One problem for patient with hyperglycemia is that it increases your blood viscosity. Wait, is viscosity COU? Saglit lang. What is the spelling of viscosity? COU ba? Or pati spelling, ano? Lalo na pag hindi mo parating ginagamit. Viscosity. No, CO lang. Viscosity. So, an increase in the blood viscosity. So, as a result, inom ka ng inom ng tubig. So, you will have polydipsia. And guess what? Pag inom ka ng inom ng tubig, one physiologic response ay ihi ka ng ihi. Polyuria. Okay? Now, increase in the viscosity of the blood will affect perfusion. Okay? Not only it will affect perfusion, it will also cause sluggish perfusion. So increased blood viscosity will result to poor perfusion. Increased blood viscosity will result to increase sluggish flow. Am I right? So what will happen if there is poor perfusion, sluggish blood flow? Of course, this will all result to poor wound healing. Am I right? This will all result to poor wound healing. And apart from that, may mga complications tayong pwedeng magsisilabasan. Now, what I usually do, I categorize the complications into three. Okay. So what are the three major complications of diabetes mellitus? We have this, what we call microangiopathy. We have macroangiopathy. Then you also have neuropathy. Expound. Micro, it's small. Angio is blood vessel, pathy, injury, or damage. There's damage in the small blood vessels. Macroangiopathy, damage, injury in the large blood vessels. Neuropathy, there's a damage, injury in the nerves. Correct? So let's begin with your microangiopathy. It affects your eyes. And this will cause retinopathy. And retinopathy can lead to blindness. What else? It affects the kidneys of your patient, causing nephropathy. And this nephropathy can result to renal failure. See, there's a lot of complications. That is your microangiopathy. Macroangiopathy, it will affect the brain. As a result, it increases the risk of stroke. It may affect the heart, increasing the risk of coronary artery disease, heart attack. See, if you notice, a patient with diabetes, they usually end up having renal failure, okay? Or getting stroke, okay? Or end up having blindness because of these complications. Neuropathy, of course, it damages the nerves. It decreases now your sensory. Sometimes you'll be surprised na hindi mo siya nararamdaman ng maayos. So there's a decreased sensory. Patient may have numbness or tingling sensation. So bottom line, it increases the risk of physical injury. Okay, but anyway, lumabas na po yung ating 5 Ps. So we have the polyuria, we have the polydipsia, polyphagia, profound weight loss, and poor wound healing. But I'm not yet done. Let's proceed on the other part. Fat metabolism. An increase in the fat metabolism will give you two conditions. Okay. What are two conditions if you have increased fat metabolism? It decreases carbohydrate uptake. You no longer use the glucose because you use fat. Therefore, if you decrease carbohydrate uptake, carbohydrate stays in the blood, because it cannot be used. It causes hyperglycemia. So wala na to. Kinonect ko na, binago ko na siya para makonect natin sa hypergly. Second is that an increase in fat metabolism will result to fatty acid production. Okay, fatty acids. And fatty acids, okay, fatty acid production will result to what? Okay, lactic acid buildup. Okay, am I right? And that will result to DKA, diabetic ketoacidosis. So DKA, as mentioned, is common to patients with type 1. Lactic acid buildup can eventually penetrate your BBB. What's BBB? Basta bading bongga. No, blood-brain barrier, and eventually it may cause diabetic coma. This is just a simplified presentation of diabetes. See, this condition stems with what? A decrease in your insulin. So it affects metabolism of these substances. Okay? So we mentioned DKA. I hope this is clear. Let's proceed. So, Sir John, how would you differentiate DKA from HHNK? Okay, here, this is your DKA. This is your HHNK. Discuss talaga ako. So DKA, as mentioned, is common to patient with type 1. HHNK is common to type. Oh my God, ano oras na? Hindi pa ako naliligo. Dang! It's 3 o'clock in the afternoon. Hindi pa ako naliligo. It's type 1, common ang DKA. Type 2, common is your HHNK. Okay, next. What do you think is the cause of your DKA? The cause of DKA is increase in your fat metabolism. And guess what? DKA is triggered. Okay? Triggered by infection, triggered by stress, triggered by non-compliance. Okay? Infection, stress, non-compliance to treatment, to therapy that can trigger DKA. Okay? Now, what about HHNK? What is the cause of HHNK? HHNK is due to hyperglycemia. Okay, hyperglycemia and fluid loss. Leading to dehydration, leading to hypokalemia. Okay? Huwag kalimutan, the higher the sugar level, the most likely you will have DKA. What is the blood sugar level of your patient? They're both hyperglycemic. In DKA, it is usually greater than 250 milligrams per DL. And guess what? The higher the sugar level, the most likely you will have DKA. What about for HHNK? What is the usual blood sugar of a patient with HHNK? Usually greater than 600. Usually greater than 600. So they're both hyperglycemic. Next, DKA, of course, they will have metabolic acidosis. Here, there is no metabolic acidosis. In DKA, patient will have positive for ketones in the urine, ketones in the breath of your patient. Whereas in HHNK, negative for ketones. Next, in DKA, patient will have positive for hyperventilation. Patient hyperventilates, or your Cosmos breathing. Here, negative for hyperventilation. If you were present last night, you will know the reason why patient hyperventilates. Remember, I said this is a form of compensation due to metabolic acidosis, because when you hyperventilate, it causes respiratory alkalosis. So that's one way of the body to respond to metabolic acidosis. In DKA, they have hypo-K. In HHNK, there is also hypo-K. Okay, so technically pareho sila ng electrolyte imbalances. So the question here is, how do we treat this one? How do you identify DKA from HHNK? What do you think will be the best test here? We do ABG analysis. Okay, one is acidotic, the other one is not. Apart from that, we do urine test. One has ketones in the urine, the other one has no ketones in the urine. Your blood sugar is not best because they're both hyperglycemic. Okay, but for the treatment, don't forget this in your NCLEX, the anticipated nursing action here. The anticipated nursing action here is to start an IV line. Okay, This is the anticipated nursing action. Start an IV line. And when you start an IV line, what is the first solution to be used and the second solution to be used? The first solution to use is an isotonic solution followed by hypotonic. We do not use, it's contraindicated. We discourage using hypertonic. Why we discourage using hypertonic? Remember, hypertonic solutions are solutions with D5, D10, 50, because D stands there as dextrose. Dextrose is glucose. So when you use that, the more it bumps the blood sugar level of your patient. Okay. We can also give potassium supplement because remember, they're both hypokalemic. And we can also give insulin to your patient. Okay. So in general, a patient with diabetes mellitus, what's the management? What is the management for patient with diabetes mellitus? When I give my lecture for the review, I always have a mnemonic for this, and we call that as NEMPE. NEMPE. And management for DM, you have your nutritional management. So dito natin i-modify yung mga diet ng patient. Don't forget that the nutritional management is the basic foundation in your diabetes mellitus control. So dito ko din discuss how many percent ang carbohydrate, how many percent yung protein, how many percent yung fats. E stands for exercise. Of course, there are things to remember about exercises, and when is the best time to exercise, general precautions when you exercise. I discussed that in the actual review. And I mentioned that exercise is essential because it will help decrease the blood sugar level. And exercise will also the risk of getting cardiovascular complications. And M, part of your management is monitoring. Okay? So you have to closely monitor the blood sugar level of your patient. Okay? And one common parameter to check here if the patient is responding well to the treatment or to check the status of the blood sugar of the patient for the past 2 to 3 months, use a glycosylated hemoglobin. Okay, so your glycosylated hemoglobin will evaluate the blood sugar level of the patient in the past 2 to 3 months. So this is a no cheat test because it will check the sugar level for the past months. Then we also have your FBS, okay, a lot of parameters to check the blood sugar. P, you also have here your pharmacologic treatment. So you say pharmacologic, you have your oral hypoglycemic, and you also have your insulin. And I usually discuss this in the review. What are the different types of oral hypoglycemic drugs? The oral hypoglycemic drugs are categorized into two. You have your sulfonylureas and the non-sulfonylureas. Okay, the main action of your oral hypoglycemic drug is to stimulate the pancreas to produce insulin. So we give this PO, and insulin is usually given sub-Q. But there is also one insulin that can be given sub-Q and can be given IV, and that is your regular insulin. And E, last there is education. So we need to educate patient. Educate about what? Educate about the complication. Educate about proper foot care. Okay, educate about taking the drugs or medication regularly. Okay, educate about exercises. Educate about proper trimming of nails. Educate about the importance of seeing a podiatrist. A lot of things. So again, we cannot cure diabetes mellitus, but we can control that. Now, I think I just want to discuss the insulin because diniscuss ko na lang man din, nabanggit ko na lang din, edi sagad-sagad na lang natin. Okay lang ba sa inyo? Do you still have enough time? If not, then I can end this one. The problem is the moment I start talking, I'm having a hard time stopping. Let me check if you have questions. Okay, hold on. Questions. Okay. What is this? Other people are watching with you. Okay. So insulin. Okay. So in insulin, don't forget the mnemonic rare in love. Okay, rare in love. And don't forget the numbers 1, 2, 3, 6, 12, 12, 16, 24. Okay. So you have your 1, 2, 3, 6, 12, 12, 16, 24, and rare in love. So this will be the pairing. Okay. That's the pairing for your insulin. So you have your rare in love. Okay. Rare in love. Ra. This is for your rapid acting. Let's use the blue one. Okay. So this is your rapid acting insulin. So instead of rapid acting insulin, these are insulin that ends with lente. Okay. Example here is your ultralente. Okay. Uh, that's the brand. That's a generic name. We use Lispro Aspart. Okay. Example here is your Lispro Aspart. That's your rapid acting insulin. Okay. Oh, bakit lente? Sorry. Mali. Not lente. These are not lente. I'm sorry. Sorry. Mali. It doesn't end with lente. It ends with log. Ano ba nangyayari sa akin? It ends with log. Example here is your humalog, novolog. I'm sorry about that. Okay, it doesn't end with lente. So rapid acting stands with log, humalog, novolog. Just like if you roll a log, it rolls rapidly. Okay, re is your regular insulin. Regular insulin. And by the way, regular insulin is a form of short acting insulin. Example here is your that's your regular insulin. And I said regular is a clear insulin. Okay? And among the insulin, it is your regular insulin that can be given, may be given sub-Q, may be given IV. But the rest of the insulins will be given subcutaneously. Siya lang pwede siya lang pwede IV. In for your intermediate acting insulin. So example here is your NPH. NPH stands for neutral protamine hagidorn. Neutral protamine hagidorn. And by the way, your NPH is a cloudy insulin. Law is for your long acting insulin. Ito na yung ends with lente. Ends with lente. Example is your ultralente. Nagkamali ako doon kanina. Sorry. VE stands for very long acting insulin. Common here is your glargine, or we call that as your lantus. Okay? What I want you to familiarize now are the peak of insulin. Peak. So this is the peak of insulin. Peak. Remember the numbers I wrote above? Those are the different peaks of insulin. Okay, remember there are in hours. So this is how are you going to write it? So this is 1, 2, 3, 6, 12, 12, 16, 24. Lahat yan sila in hours. So if you'll be asked in your examination, regular insulin, okay, regular insulin was given at 8 o'clock in the morning. Was given at 8 o'clock in the morning. What time you will expect hypoglycemia to occur? What time you'll expect hypogly if you give regular at 8 a.m.? The peak of your regular is 2 to 3 hours. So what's the answer in your NCLEX? That would be 10 to 11 a.m. So you would expect hypoglycemia to occur on these hours, on this period. That's 2 to 3 hours after giving the insulin. Okay, so if you gave rapid acting, if you gave Lispro aspart at 9 a.m. or 7 a.m., 7 a.m., what time you'll expect hypoglycemia? That's 8 a.m. That's an hour after. So the placement will be 1, 2, 3, 6, 12, 12, 16, 24. And don't forget your rare in love. This is so powerful and helpful in your examination. Okay, so I hope that's it. You learned something, guys. Okay, what else? Oh, nag-research talaga si Raquel ng viscosity. Ako nga eh. Ano ba yung spelling ng viscosity? C-O-U ba o C-O lang? Anyway, alam mo naman yung mga tao sa social media, ang galing mang bash. Mali-mali spelling, mali-mali. Okay, so I hope you learned something, guys. I still have a few more minutes. Anything you want me to talk about, to discuss? Raquel, I hope I answered your questions. Actually, some. No? Kasi kung i-discuss ko yung lahat, my God, mauubusan tayo ng oras. Okay, what else? Welcome, Raquel. Let's see. Okay. Sir, replayable po ba ito? Yes! Replayable po ito. Don't worry, I won't delete this stream. Meron ka ba regular live sa YouTube, sir? Meron po ako sa sa OnlyFans. Wala. No, wala po. So, you have to follow me para makuha niyo yung mga... Kasi yung ginagawa ko sometimes, depende sa mood. I think I'm in a mood of doing live lecture or giving some live stream. No problem, Alan Ferrer. You can replay this anytime you want. Do you have other topic you want me to talk about? Yeah, you can follow me, no problem. But anyway, thank you so much, guys, sa mga naging estudyante ko before. Thank you so much for staying with me. Okay, my God, I can't imagine. I mean, I've been doing this for 21 years. Mga ibang estudyante ko, chief nurse na, or ibang estudyante ko, charge nurse, manager. I'm just glad that somehow naging part ako ng nursing career nila. Sir, yung 7 p.m., yes. 7 p.m. Hemo po, sir. Hemo, blood. What about blood? What about blood that you want me to talk about? What specific topic in blood that you want me to talk about? Dito ka sa Pinas, sir? No, I'm in the US. It just so happened that I don't have work today. I'm a traveling nurse, so I work 3 days a week, 4 days off. Can you discuss autonomic dysreflexia? Yeah, sure. Autonomic dysreflexia is also called autonomic hyperreflexia. This is a common problem of a patient with spinal cord injury that usually happens to patient with SCI above T6 or thoracic 6. And if the patient has autonomic dysreflexia, it is usually triggered by a distended visceral structure, just like your urinary bladder. Not only that, autonomic dysreflexia is also triggered by physical stimuli, just like your uh, fecal impaction, or a very rough linen, a hard pillow, a heavy blanket, or shall we say, yung mga room temperature na hindi hiyang sa pasyente. That's it. So it can trigger autonomic dysreflexia. And a patient with autonomic dysreflexia will manifest hypertension, severe throbbing headache, a lot of neurologic deficits. That's your autonomic dysreflexia. And autonomic dysreflexia happens after spinal shock. So mauuna yung spinal shock. After spinal shock, you will have autonomic dysreflexia. So what is spinal shock? Discuss na naman ako. Spinal shock refers to sudden loss of spinal cord functioning. Okay? Mabuti na. Okay. Yun na yun. So okay na tayo. So one management of autonomic dysreflexia is to make it sure that you have a good urinary output. So you need to have an indwelling catheter. We're not supposed to limit catheterization to your patient. And sometimes we give medicine. Usual medicine given to patient with autonomic dysreflexia is apresoline. That's your hydralazine. Apresoline hydralazine is a potent vasodilator. NGN, actually I made a video about NGN at nabash nga ako doon, nakakaloka. Kasi ba naman yung staff, ang ginamit nila na clip, yung sinabi ko lang na the new generation NCLEX will commence April 1st till March 31st of 2026. So, yung mga ibang nurses nagalit, na upset, bakit daw? Yun lang parati kong sinasabi, hindi ko po kasalanan yun. Yun po ang ginamit ng staff na clip. Yung explain ko ng NGN, 1 hour and 30 minutes ko yun in-explain. It just so happen, yun ang ginamit ng staff sa marketing. Nabash ako dun. Wala akong pakialam. Nanonood na nga lang sila nang babash pa. And I don't care. Sir, magkano sahod ng travel nurse? Ito pala, sir, pong Rogam ba yun sa blood? Rogam. Okay, we'll talk about Rogam in a bit. Anyway, sir, magkano yung sahod ng travel nurse? Depende po sa agency. Basta ang masasabi ko lang, ang ganda ng bayad sa travel nurse. Hindi po kayo magsisisi. Mas mahirap ba ang NGN? I don't know, but for me, it's exciting. Okay, discuss na tayo ng Rogam. Okay. Okay, let's talk about blood. I think this will be the last topic. Kasi mag 3:30 na, tapos may klase pa ako mamaya alas 3. Yung EKG. Okay, so this is a requested topic by Marie Rivas Blood about Rogam. I will talk about blood first, okay, so that you will understand Rogam, yung tawag dito, RH incompatibility. Let's try to turn off the background music. Okay, let's talk about, where's that whiteboard? This will be my last topic, and then after this, maliligo na po ako, mag-aalas 3:30 na. Okay, so blood, let's talk about blood. Blood is the only fluid connective tissue. It constitutes 8% of the total body weight. Do you know that? If you weigh 80 kilograms, 8% of that galing po sa blood. And blood is the only fluid connective tissue. Your blood serves 3 basic functions. And what are the 3 functions of blood? Blood is important for transportation. Blood is important for protection. And blood plays a vital role for temperature regulation. Okay? So protection against infection, protection against bleeding, because in the blood we have platelets, in the blood we have clotting factors. So it protects against infection and bleeding. Anyway, so our blood has 2 basic components. We have the plasma. If you were present a few days ago when I talk about fluid compartments, you will appreciate this. Plasma, and then you have the formed elements. Plasma is 55% of the total blood volume. Formed elements will be 45% of the total blood volume. God, my dad is calling me. I'm online, so I cannot pick up the phone. So I said that plasma is the liquid part of the blood. Form elements tatlo yan. You have the RBC, you have the WBC, and you have platelet. So I want to talk about blood formation first. So this thing happens inside the bone marrow. So inside the bone marrow, there is this what we call what do you call that cell again? Pluripotent stem cell. Plurito? Pluri, pluripotent stem cell. So when you say pluripotent, it's different from omnipotent and different from impotent. When you say pluripotent stem cell, it means to say that from a single cell, it will divide into different types of cells. Okay. So this pluripotent stem cell will divide into two. Okay, two cells. We have the we have the myeloid. Ano nangyayari sa spelling ko ngayon? My God. We have the myeloid and we have the lymphoid. And these myeloid cells will transform into three specific cells. So we have the RBC, we have the WBC, and the platelet. So these cells, RBC, WBC, platelet, the RBC, WBC, platelet, galing yan sa myeloid stem cell. That is why if you have a condition called polycythemia vera, there is myeloid proliferation. So because of myeloid proliferation, that will increase the RBC count, the WBC count, and platelet count of your patient. So it's a myeloid problem. Lymphoid, on the other hand, will transform into B lymphocyte and T lymphocytes. B and T lymphocytes. These B lymphocytes or B cells will transform into what we call plasma cells. And plasma cells are cells responsible for your immunoglobulins or your antibodies. Okay, I hope you can still remember your GAMED or your GAMED. Immunoglobulin G, immunoglobulin A, immunoglobulin M, immunoglobulin E, immunoglobulin D. Okay? Your T lymphocytes or T cells are somehow considered as useless. Somehow considered useless. It will become useful if the T lymphocytes will go to your thymus. Okay? Where is your thymus situated? Your thymus is located at the back of the sternum fronting the heart. When you were still young, your thymus is huge. But when you grow old, the thymus decreases its size. Okay? So once the T lymphocytes enters the thymus, there will be proliferation and differentiation of your T lymphocytes, making the T cells now more useful. So it will transform into what we call helper T cell, magiging memory cell, magiging killer cell, and a suppressor T cell. Suppressor T cell. Please check the spelling if suppressor is double S or double R or double P. Anyway, basta yun na yun, suppressor. See, it will make your T cells now more useful. Other name for helper T cell is your CD4 cell. So this is the thing we check for patient with HIV infection. Okay, if the CD4 count is too low and a patient has opportunistic infections, we call that as your AIDS category. So AIDS is a full-blown HIV infection. Okay, so magiging ano na siya, magiging useful na yung mga T cells when they get inside the thymus. Okay, by the way, so the B cells or the B lymphocytes are the cells responsible for what we call humoral response. Humoral mediated response. That is under the concept of immunology. The T cells or the T lymphocytes are cells responsible for cellular mediated response. Cellular mediated response. Some book it's cell mediated, some book it's cellular mediated response. Remember, there are two responses, the humoral mediated and the cellular mediated response. That's under the concept of immunology. Meron pa tayo part ng immunology concept, yung um, active and passive immunity. If you can still remember that, the natural and the artificial passive active immunity. Anyway, that will be for another concept. Now, let's talk about the myeloid. Among the cells here, the most abundant is your RBC. Okay, now, this is the RBC. RBC. There are molecules or pigments inside the RBC, and you call those as your hemoglobin. Okay, your hemoglobin is divided into two. You have the hem and the globin. Hem is derived from protein, not protein, from iron. Globin is from protein. Okay? Remember that hemoglobin plays a vital role in carrying gases. What specific gas binds with the hem? It's your oxygen. What specific gas binds with the globin? It's your carbon dioxide. Guess what? If you don't eat iron-rich food, hem is not formed, decreasing hemoglobin, okay, causing a condition called iron deficiency anemia. If there is a problem with the globin, that will also cause anemia, but the appropriate term there is what we call thalassemia. So may mga specific siya na part kung anong nasakit. So this will cause iron deficiency anemia. This part here will cause thalassemia air. Sa thalassemia, there are two types, the thalassemia major and the thalassemia minor, AB. Okay, now, inside the RBC, okay, may tinatawag tayong protein na lumalabas sa examination, yung RH incompatibility. But anyway, I need to erase this one first. Okay, look at the different blood types. You have type A, type B, type O, and type AB. Okay, so you have here the antigen and the antibody. So tell me, if your blood type is A, what is your antigen in A? Antigen in, if you have your blood type is A, you have antigen A, you have antibody B. Correct? If you have blood type B, your antigen is B, your antibody is A. Correct? If you have a blood type of AB, you have antigen A and antigen B, and you don't have antibody. If you have blood type O, you don't have antigen, but you have antibody A and antibody B. Correct? Tama po ba? I hope so. So that is why, kung wala kang antigen sa O, you can give type O to any type of blood. Kaya nga type O is the universal donor because it does not contain antigen. As a result, there will be no immune reaction. Okay? If you have a blood type of AB, okay, you can receive any type of blood because you don't have antibody. Okay? Kaya nga, pag sinabi nilang universal donor, a universal recipient. Okay, you need to see me when I say this. So when you say donor, you give the drug. You give the drug, you give the blood. Donor ka nagbibigay ka. Kaya sa Bisaya, kung donor, type O, donor. Recipient, tumatanggap. Ambi, AB sa Bisaya. Okay? So universal blood donor is O. The universal blood recipient is AB. Donor O, recipient is AB. Okay, but it's not enough. You should know the RH component of the blood. If the RH, if the blood is RH positive or the blood is RH negative. What is the relevance if the blood is RH positive? When you say RH positive, that is the blood with RH antigen. When you say RH negative blood, means a blood without RH antigen. Okay? RH incompatibility is common to a patient or person with RH negative blood. Okay? I will explain that in a bit. So, ganito yon. So, kung RH positive, may RH antigen. RH negative, no RH antigen. If there is RH antigen, it can trigger immune response. It can trigger immune reaction. Simple. Here. Now, this, I will explain RH incompatibility in two concepts. This is the concept of maternal child nursing. Okay, so let's say this is a mother, okay, mama. Mom is RH negative. Okay, remember, the RH negative blood means that the blood doesn't have an RH antigen. Okay, so this is the placenta, this is the baby. Okay, and this is the umbilical cord. The baby inside is RH positive. Did you get the difference? Mom is RH negative. The fetus inside is RH positive. In short, the blood contains RH antigen. And by the way, where can you find the RH antigen? The RH antigen can be found inside the RBC. Okay? Anyway, let me check if you have any questions. Okay. So take note, the only link between maternal and fetal is actually the placenta. During delivery, okay, during delivery, or not only during delivery, if there's an accident, that accident resulted to fetal blood leakage. So technically, if the blood of the baby or the fetus enters the maternal circulation, even 1 to 2 drops of blood, that is enough to cause immune reaction. Take note, the blood of the baby has an antigen. The blood of the mother does not have an antigen. So when the fetal blood enters the maternal circulation, since that blood contains antigen, once antigen enters the bloodstream of the mom without RH antigen, what will happen now is that it triggers immune response. Okay? And this immune response will cause reaction, causing release of an antibodies. These antibodies now will destroy the RH antigen. The problem there is, okay, pag nakalabas yung baby, when the baby has been delivered and antibodies are there, antibodies are actually late. Where's the RH antigen? There's no more RH antigen because the baby was already delivered. Can you follow? So it did not affect the baby. Am I right? In short, it will not affect the first pregnancy. But succeeding pregnancies, provided that the baby is RH positive, that's the concern. That's the problem. Why? Following year, the mom got pregnant again. It just so happened that the second child is RH positive. It has RH antigen. Remember that the antibodies formed prior to this pregnancy, it will be activated and it gets inside the area and destroys the RBC of the developing fetus. Why will it destroy the RBC? Because again, the antigen can be found inside the RBC. What will happen now? This mom will have a miscarriage. Okay? Mahuhulugan siya. In short, Sa RH incompatibility sa maternity nursing, it will not affect the first pregnancy. It will affect the succeeding pregnancies, provided that the succeeding pregnancies, the baby is RH positive. So what will you do as a nurse? As a nurse, if the mom is RH negative, if the mom is RH negative, within 72 hours, okay, post delivery, you have to give ROGAM. Okay? Why do you have to give ROGAM within 72 hours after delivery? The purpose in giving ROGAM is to prevent antibodies formation. Did you get that? So I hope that is clear. The purpose in giving ROGAM is to prevent antibodies formation. So remember, the first pregnancy was not affected because when antibodies were formed, it was too late. The baby was already expelled. It was already delivered. Okay, so it will just wait for the next pregnancy if you have an RH positive baby. This is for maternity nursing. Okay, but for medical surgical nursing, let's have another explanation. This is our patient, okay, that the blood type of the patient is RH negative. Again, the patient is RH negative without RH antigen. We need to do blood transfusion. When we do blood transfusion, what blood will you give to your patient? Can we give RH negative blood or can we give RH positive blood? Ideally, you give RH negative blood. It doesn't contain RH antigen, so no immune reaction. Can we give RH positive blood to RH negative patient? In emergency cases, listen carefully to my statement. Baka na naman ibabash na naman ako nito ngayon. We can give RH positive blood to RH negative PK people or patient provided that that is his first time to receive the blood. Succeeding transfusions throughout his life or her life must be RH negative. Why? The moment you give RH positive blood to a patient, to a person who is RH negative, when that RH negative blood enters the circulation, enters the patient, it will trigger immune response, releasing or causing antibodies production. When antibodies, immunoglobulins are produced, and you give another RH positive the second time around, it will destroy its own blood. Okay, patient will die. That is why succeeding transfusions after giving RH positive the first time around, succeeding transfusions must be RH negative. Clear? This condition, incompatibility, is common only to patient who is RH positive. RH negative positive. What if the patient is RH positive? Tingnan natin na. What if the patient is RH positive? If the patient is RH positive, can we give RH positive blood? Can we give RH negative blood? Can we? Yes, it's okay. Why? If you have RH positive blood and you give RH positive blood, it doesn't make any issue. Why? They both have RH antigen. If you give RH negative blood, it won't be an issue because again, you give a blood without RH antigen. Doesn't make any fuss, no issue. Because the patient himself or herself has a blood with RH antigen. Ang problema lang if yung patient mo mismo is RH negative. So wala tayong issue if the patient is RH positive. Only if the patient is RH negative. So going back. So if the blood type of the patient, dito na, let's do specific blood type. If the blood type of the patient is A positive, A negative, B positive, B negative, O positive, O negative, AB positive, AB negative. Sige nga. Oh my God, mahaba-habang usapan to. If the blood type of the patient is A positive, A positive. What blood can you give? Okay? Ano ba yan? What blood to give? Okay? If the blood type of the patient is A positive, what blood can you give? You can give A positive blood, you can give A negative blood, you can give O positive blood, you can give O negative blood. Okay? If the blood type of the patient is A negative, you can give A negative blood, you can give O negative blood. If the blood type of the patient is B positive, you can give B positive blood, you can give B negative blood, you can give O positive blood, you can give O negative blood. If the blood type of the patient is B positive, B negative, you can give B negative blood, you can give O negative blood. Woo. If the blood type of the patient is O positive, you can give O positive blood, you can give O negative blood. If the blood type of the patient is O negative, you can give O negative blood. If the blood type of the patient is AB positive, you can give AB positive blood. You can give AB negative blood. You can give A positive blood, A negative blood, B positive blood, B negative blood, O positive blood, O negative blood. You can give any blood. If the blood type of the patient is AB negative, you can give AB negative blood. You can give AB negative blood. You can give A negative blood. You can give B negative blood. You can give O negative blood. Okay, so these are the bloods that you can give to your patient. Now look at the distribution. Look at the distribution. What is the universal blood donor? I said O. What is the universal blood recipient? I said AB. Now, to be specific, what is the universal blood donor? The universal blood donor, is O. The universal blood recipient, I said, is AB. But be specific, positive or negative. Look, O negative, 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 O negative can be given to any type of blood. Therefore, what is the safest blood? The safest blood is O negative. Why O negative is the safest blood? O, because that is the universal blood donor. Negative, because it does not contain Rh antigen. No Rh antigen would mean no immune response, no immune reaction. Therefore, O negative is the safest blood. What about the universal blood recipient? Look, what specific AB can receive any type of blood? It's your AB positive. It can receive any blood. Therefore, the universal blood recipient is AB positive. Okay? So I hope this is clear. So don't forget this in your examination. Safest blood is O positive. Recipient is AB positive. Sorry, universal blood donor is O negative. Universal recipient is AB positive. I hope I answered your question. Okay. Ano pa itong mga tanong dito? Bisaya ka, sir. Taga-asa ka, sir. Yes, Bisaya ako. I'm from Davao. Okay, I hope I answered your question, Raquel de Castro. Okay. Anyway, do you have any questions? I hope you answered your RH incompatibility. Now, if you want me to discuss any topic, just let me know and I will discuss that most probably, let's say tomorrow, if I have time. Okay, just let me know. Okay? May mga topic ba kayong gusto kong i-discuss tomorrow? Don't forget tonight, if you want to join, I will have EKG reading tonight. That's part 2. Please do not join my discussion tonight if hindi nyo na watch yung part 1. Okay? You need to watch the part 1 first before you watch the continuation of ECG reading tonight. That will be tonight, 7 or 8 p.m. Central Standard Time. I don't know what time will that be in the Philippines. Do you have any questions or any topic you want me to talk about tomorrow? Any topic you want me to talk about tomorrow or to discuss tomorrow? So we talk about EKG introduction. I even mentioned uh, diabetes mellitus today. We talk about autonomic dysreflexia. We talk about blood, your RH incompatibility. Do you have any topic that you want me to talk tomorrow? Or bukas ko na lang itanong, no? Impromptu na lang tayo kung anong topic gusto yung i-discuss ko bukas. If I don't know the topic, I will let you know. If I know, then I will discuss it. Pharmacology, okay, we can talk about pharmacology tomorrow. So siguro ang approach natin sa pharmacology per system, which is better. So my approach will be per system. So let's say cardiovascular. What are common drugs for cardiovascular? Or respi. What are common drugs given for respiratory? Here, ano ba to? Paano magkaroon ng pregnancy pa lang nagkaroon ng blood interaction yung mother O negative O positive? Okay, I can discuss that, but I don't want to overlap your maternity concept. I will say that. Basta tandaan lang, yeah, per system, Raquel, RH incompatibility is common pag yung patient natin is RH negative and receive an RH positive blood. Yeah, per system tayo para mas madali nating ma-appreciate. Okay? So anyway, I really have to go because it's almost 4 o'clock. Hindi pa ako naliligo. And I have a class at 7 or 8 later. So thank you so much, guys, for staying. I hope you learned something. Thank you so much. God bless everybody. And I hope to see you tonight and tomorrow for a free NCLEX review. Okay? God bless and keep safe, keep warm. Bye, everybody.